Hi, my name is Shari Ferney, and I am presenting my DMP project, Implementing Collaborative SMART Goal Setting in Patients with Diabetic Wounds in an Outpatient Wound Care Clinic. Thank you for watching my presentation today. These are the members of my committee. My chair is Dr. Gordon West. My second reader is Dr. Boniface Stegman, and my community member is Dr. Scott Grover. Type 2 diabetes is a growing global health crisis that affects 537 million adults worldwide. This number is expected to reach 700 million by 2045. In the United States, diabetes is the most expensive chronic illness for both individuals and healthcare systems. Poor glycemic control, which is usually measured by hemoglobin A1C, significantly impairs wound healing by reducing perfusion, increasing inflammation, and increasing infection risk. Because of these factors, people with diabetes face a 25% lifetime risk of developing foot ulcers, which are associated with high rates of infection, amputation, and mortality. There is clear evidence that links glycemic control to improved outcomes. It is important to remember that type 2 diabetes can be prevented and treated with lifestyle modifications. However, self-management remains limited due to behavioral and psychosocial barriers. During my literature review regarding management of type 2 diabetes, there were three key themes emerged. First, patient activation improves clinical outcomes. Second, collaborative care increases self-efficacy. And third, self-directed goal setting encourages sustained health behavior change. A key strength of the literature review was generalizability of the findings. First, research was conducted in various countries. This included Australia, Brazil, Saudi Arabia, and across North America, including Texas, North Carolina, Indiana, Minnesota, and all of the Canadian provinces. The broad geographical representation emphasizes that integrating patient-centered care improves outcomes globally. Second, most studies were conducted in outpatient primary care settings. In fact, all but one were conducted in outpatient primary care settings, making the research applicable to other outpatient care settings, such as wound care. The clinical practice guidelines of patient-centered care is a systems-level approach to increase disease control, treatment adherence, and efficiency. The Institute of Medicine's 2001 report, Crossing the Quality Chasm, identified patient-centered care as an essential foundation for healthcare quality and patient safety. The World Health Organization also advocates for patient-centered care, and the National Institute for Health and Clinical Excellence identifies patient-centered care as evidence-based healthcare. The World Union of Wound Healing Societies issued a call to action to implement patient-centered care in wound management in 2017. Shared decision-making and patient-centered care are vital to managing chronic conditions. This project was based on Imogen King's theory of goal attainment, which emphasizes nursing as a dynamic interpersonal process where nurses and patients mutually communicate, set goals, and take action to attain the goals. The focus on the nurse-patient relationship, communication, and mutual goal setting provides a suitable framework for this project. It emphasizes the nurse-patient relationship and aligns well with the principles of patient-centered care. This theory considers both the patient and the nurse as individuals engaged in a collaborative problem-solving partnership. It values the perspectives of both parties and emphasizes the importance of working together to achieve healthcare goals. The theory of goal attainment is a middle-range interactional nursing theory that focuses on the collaborative relationship between patients and nurses, as well as the process of setting and attaining goals. The theory comprises 4 key concepts: perception, communication, interaction, and transaction. These concepts are interconnected, forming a continuous process that provides structure to the theory. King emphasized that the central focus of nursing is the interaction between individuals and their environment. Factors such as perceptions, needs, values, and goals significantly influence the relationship between the nurse and the patient. Through effective communication, both parties can address and explore healthcare and the goals and identify ways to achieve the goals. Transactions occur when mutual goals are established and there is a consensus on how to reach those goals. The assumption of the theory of goal attainment emphasizes that all individuals should be respected and treated equally. Patients have the right to participate in decisions affecting their health and well-being. They also have the right to accept or refuse health care and to receive information about their health. Furthermore, nurses have the responsibility to educate patients about their health and to assist them in making informed decisions. This project integrated this theory into daily outpatient nursing practice and shifted nursing care toward a relationship-centered, evidence-based model. The goals of this project were to enhance patient activation, self-efficacy, and self-management as demonstrated by reduction in A1C levels. Additional objectives included integrating patient-centered care constructs into the wound care setting, improving clinician-patient communication, promoting shared decision-making, and increasing clinician engagement, as well as improving nurse communication between patient visits. To achieve this, the intervention needed to be both efficient and effective. It needed to be seamlessly incorporated into the visit workflow, and it needed to be integrated into the electronic health record and easily and quickly charted. My research question was, in patients receiving diabetic wound care in an outpatient setting, does the implementation of collaborative SMART goal setting reduce A1C levels in 90 days? The process of my quality improvement project was first to conduct a needs assessment of the clinic. I then developed a collaborative SMART goal setting tool based on my literature review that enabled the identification of weekly goals and their categories. These categories were things such as nutrition, physical activity, glucose monitoring, foot care, medication, wound dressing, and any other topic that was relevant to their healthcare. It could be remembering to check your shoes for foreign objects or making sure you wear shoes in your house. Any little thing that the patient was having difficulty with. It also identified patient perceived barriers to achieving that goal and provided a space to document their perceived barriers and the collaboration between the nurse and the patient to identify facilitators to achieving the goal or to overcoming their challenges and barriers. So there was also space to document nurse barriers to goal setting. Staff, as you can see here in my little infographic, the process of the project, starting with the initial visit, recording their A1C, and then participating in weekly collaborative goal setting. The staff received education on how to use the tool prior to its integration, and they also received extensive education regarding how to document the application and how to incorporate it into their wound care visits. My research used a quantitative, longitudinal, and retrospective chart review of pre and post intervention A1C levels. It was conducted in a hospital-based outpatient wound care clinic in the Western United States. The tool was integrated into the electronic healthcare record, and it was used for all patients and every visit, but only data from individuals with chronic diabetic wounds were extracted and analyzed. The pilot period went from February 1st, 2025 to September 1st, 2025, and the data was extracted between September 2nd and September 15th, 2025. This allowed for the A1C levels to be drawn 90 to 100 days to 110 days apart. A total of 14 patients A total of 14 patient records met the full inclusion criteria for analysis. We had several patients who refused participation. We had a couple patients who were healed prior to the 90 to 110 day mark, and we had 2 patients pass away. Descriptive analysis demonstrated minimal change in A1C values following the intervention, with comparable variability across time points. Testing for normality of data distribution is needed to justify parametric testing. So both the Shapiro-Wilk and a Komarov-Smirnov tests were used for this. After tests of normality were conducted, a 1 and 2-tailed paired t-test was then used to compare pre and post A1C levels. Effect size helps evaluate clinical relevance, and the power analysis assesses whether the sample size is sufficient to detect a meaningful effect. The test of normality indicated a normal distribution of the data, as you can see here on the graph. The 1 and 2-tailed t-test showed that the reduction in A1C levels was not statistically significant, and therefore we cannot reject the null hypothesis. The calculated effect size was small, indicating a minimal practical difference between pre and post intervention values. This study has low statistical power with a final sample size of 14 that falls well below the target of 41 to 45 participants. Power analysis indicated very low statistical power, limiting the ability to detect meaningful differences. There was little change in the mean A1C, and the variability between pre and post intervention values was similar. Overall, the post-intervention A1C levels did not differ significantly from the pre-intervention levels. Interestingly, the 3 patients with the highest pre-intervention A1C levels had lower A1C levels post-intervention, as shown in the graph. This study had several limitations and should be interpreted with caution. First, the pilot period occurred during a time of unprecedented low volume and low census at the wound clinic, which resulted in a small sample size and very limited statistical power. In hindsight, the pilot period was too short, lasting only 7 months. Additionally, the sustainability of the intervention has been challenged by staff turnover and leadership changes within the clinic and the hospital. Prior to the implementation of the collaborative SMART goal setting tool, the EHR was very limited to a basic education checklist. It didn't have the ability to track prior teaching. It was lacking an area that focused on self-management or what the patient could do to work to improve their health. So it basically a sheet with just radio buttons to click of, we discussed compression, we discussed offloading, we discussed nutrition, I think we discussed hyperbaric therapy, things like that, but it wasn't patient specific. It didn't have a place to say what specifically you talked about. In addition, the patient time with nurses was spent casually visiting. In the wound clinic setting, you see the same patients 1 or 2 or 3 times a week for several months, and it's very easy to get into excuse me, a very casual visiting type relationship instead of advocating for the patient's health. And anyway, so although the research component of the quality improvement project was statistically insignificant, the project made a meaningful impact on the workflow, the care delivery, and the clinic culture. Integrating the collaborative SMART goal setting tool improved the efficiency by enhancing continuity of care across visits and supporting more focused patient-centered interactions and strengthening communication among nurses and patients and nurse to nurse. You were able to go in and see specifically what the patient was working on, whether that was putting clean socks on every day, checking my shoes to make sure there's nothing in my shoe, or increasing protein intake. And you could see that what the nurse had discussed about what's going to make this hard for you. What do you perceive as being hard about achieving this goal? And then the place where it was documented, the facilitators that were discussed, such as and led to a real dynamic between the nurses and the patients in collaborating and trying to overcome barriers to healthcare. So it was easy to see what the prior visit focused on and what you could build on at the next visit. Or if they didn't meet the goal, what went wrong? What can we do to help you? Do you want to change a goal? Do you want to do the same goal? Basically, a really good assessment on how the patient was feeling about their healthcare goals and about what they wanted to do. So nurses also reported increased satisfaction and empowerment, which reflected a shift towards shared decision-making and greater patient engagement. Oftentimes, wound care can get frustrating because you feel like you care more about their health or about their feet than they do. And so every single nurse came to me and told me that they finally felt really good about what they were doing and what they were doing to help that patient help themselves. So since the intervention is integrated into the electronic health record, it can be easily implemented within wound care clinics across the healthcare system, or any hospital or clinic that uses that same electronic healthcare record at minimal cost, and it can potentially lead to long-term savings through increased patient self-efficacy and improved chronic disease management. This quality improvement project has important implications for practice. For nursing, it empowers their role as educators, coaches, and advocates for patient health. Additionally, integrating the collaborative goal-setting process positions nurses as leaders in care coordination, behavior change, and chronic disease management within a value-based healthcare system. This will be especially important as the incidence of chronic diseases continues to increase. For my own practice, I've learned that incorporating patient-centered care constructs and shared decision-making into each visit is essential for quality healthcare. It's so important to have open, honest conversations in a non-judgmental way, address patient-specific barriers, and meet the patient where they're at. Take small goals and build on successes. The goal-setting intervention can easily be implemented in other outpatient settings, and it can lead to better engagement, higher quality healthcare, and improved outcomes. By increasing self-efficacy, patient activation, and self-management behaviors, this intervention will positively affect individuals and systems by reducing costs and burdens of chronic diseases. In conclusion, this quality improvement project incorporated the King's theory of goal attainment, patient-centered care constructs, and motivational interviewing principles into the daily outpatient nursing practice, with interactions being appropriately and quickly documented. It empowered patients to take simple steps to improve their health and build on each little success. And it also empowered nurses to really embrace their role and their influence on patients' lives. So there are several things that I would do differently. First, I would prioritize a larger sample, either by extending the pilot period or by integrating the intervention across several outpatient wound clinics simultaneously. I would also focus more on the project's sustainability through ongoing education, not only for new nurses, but for new leaders and managers within the clinic and hospital, and help them to understand the principle behind the project. So the DMP program has taught me the importance of translating evidence into practice and leading systems level change to improve patient health and to improve population health. And taking that new research, the new evidence, and incorporating it into daily healthcare setting is really, really fun and really, really satisfying to help people in that way. It's more of a feeling I can help more patients by improving the healthcare setting and incorporating evidence-based practice than just my one-on-one nursing. So this, and basically it starts at the very most basic. Patients start with very small goals and very small goals and ideas of what they want to do to change and to do better. And I am the same way. It starts with the seemingly small stuff of having compassion and respect for all individuals and knowing that all individuals deserve quality health care. And I've really learned and I've grown through the program. The program has taught me that I have more ability, strength, and resilience than I ever thought I had. And it has increased the confidence I have in my own knowledge and my own skills. So I'm very grateful for the program, and I'm very, very grateful that I switched from getting my master's to getting my doctorate. I have changed a lot for the better. So these last two slides are my references, and thank you for listening to my presentation today. I really appreciate it.